Bill, I was curious, the survey results, they revealed a relatively high level of satisfaction of providers using their EHR systems for analytics to understand their current risk profile. What would you say are some strengths with using an EHR, and what are some of those key areas where there are gaps?
Yeah, I'm surprised by how many people are satisfied with the EHR for analytics. I think EHR is great. We have Epic, which is a very good program. And it's very good for looking at things like quality gaps. How many patients have had mammograms, colonoscopies, diabetic eye exams? But it is not good, first of all, making sure that we're documenting patients' problems well, especially HCC codes. And it is really not, from my standpoint, very effective in helping capture HCC codes. We have a problem list that just gives a list of diagnoses, and it usually will say that this is an HCC code. But those are for only codes that were documented in the past and not recaptured. It says nothing about what the patient may have as far as conditions clinically, or even things that they find on scans or lab work that may be additional HCC codes. So the EMR, to me, is not very effective at all in capturing new HCC codes. It's okay in capturing things that have been captured before, but based on our work with SCIO, we know we're grossly underestimating the number of HCC codes that are applicable to patients. And it really is across our provider, from providers that see a lot of patients to providers that don't see a lot of patients. These are all primary care providers, and their missing HCC codes is pretty much across the board.
And I'd like to add something to that. I think Bill brought up a really good example. You know, the electronic health record was designed for a different purpose, order entry and billing, et cetera, and giving a comprehensive picture of what's going on with the patient. But you took an example, let's say a provider is treating a quadriplegic. Well, the provider knows that's a quadriplegic. It's probably on the problem list. It's documented all over the EHR. But if the provider doesn't document that in a specific way every year to indicate that that is a paraplegic and that they're evaluating any issues that the patient may have and treating it accordingly, then that organization will not get credit for that particular condition from an HCC code perspective. That information will not go to CMS. The risk will not be adjusted accordingly. And it's, you know, it's something that is in the EHR and very evident, but it's a little bit misleading in that the provider doesn't know they have to document it in that specific way, and so they're missing out on that. And again, the EHR has a very comprehensive view of the patient and historically on the patient, but it isn't always ideally suited to the documentation required for risk adjustment purposes.
And I would emphasize it's very poor in the educational aspects of risk of HCC codes. For example, our problem list routinely prompts physicians to code for HCCs for cancers, and yet it doesn't indicate that the cancer has to be active or the patient has to be under active treatment to qualify for the HCC code. Our clinicians don't know that usually, and so we're overcoding in some situations and undercoding in other situations. So we need to involve education either externally from the EMR or somehow integrated into the EMR.
Thank you both for talking about the EHR and the issues and solutions that go along with that. Donna, I was wondering from your perspective, what do you think is the key ingredient to gaining an accurate picture of risk?
I think it's a more comprehensive data view of the patient. So that includes not only what's recorded at the encounter and the examination, but also what was billed on the patient or what was paid, and then what information went to CMS to adjust the risk. Sometimes there's gaps in that information flowing all the way through to the system. And again, the provider organizations need visibility to that information. And, you know, there's more and more we're hearing in the industry about other things that might not be in the EHR today, social determinants of health that are huge drivers of healthcare costs, et cetera. So I think relying on one single source of information is a shortfall for the industry. We need to look a little broader at the EHR and also patient-supplied data and survey data and also claim data and also CMS data to get a more accurate picture for risk and for population demographics.
I'll just add as a provider that the claims data has been incredibly impressive for me to look at. I didn't even know it existed. And until SCIO presented it to us, we had no idea how many potential outside claims for HCC codes had been made. And more importantly, it gives us information on who we might look at as far as patients to see what HCC codes they may be missing. So it all works into one plan that we have with SCIO, and I think we're much better suited for dealing with risk and HCC coding since we've aligned with them.
Yeah, a lot of the electronic health records focus on what's in their network or what's in that particular electronic health record system. So providers that are outside of that particular EHR or outside of that network, those visits may not be visible to the provider, and they can contribute significantly to risk and to the conditions and the services. They certainly have a lot to do with the services the patient, healthcare services the patient is seeking. So it does require a broader view, I think, of information to be able to close those gaps.
Excellent. So, Bill, I wanted to go back to one of the slides. The survey indicated that nearly 45% of respondents are unable to take action on closing open care or documentation gaps. Do you think did this surprise you, knowing many of them are using their EHR systems?
Having been through this over the last 2 years with the new EMR system, I have to say I'm not surprised. How you put the information into the system is totally the determinant of what you get out of the system. So, for example, we had a big corporate objective for diabetic eye exams, and we knew that we were doing really well with performing diabetic eye exams, but if they aren't put in the Epic system under health maintenance, there's no way of pulling it out. So you don't get everything in the EMR presented to you for these quality gaps such as that. So it takes a lot of time to be able to learn exactly how to put things into the EMR before you get valuable data out. One of the real problems we have is when we're scanning data from an outside entity, such as an ophthalmology report or a mammogram from an outside vendor. If you just scan it into Epic, it doesn't get added to your health maintenance unless you code it correctly. So we knew we were doing a good job on mammograms and diabetic eye exams, and yet we were falling multiple times below where we thought we should be until we really got our IT people to make it much more obvious to people in the offices where these things had to be added. So I'm not surprised. It's not something that you just open up an EMR and have everything presented to you. It's a lot of work. But if you do it, it will eventually give you that quality information.
Sure. And even though you may achieve a very high score on quality gaps in one area, for example, that doesn't mean that you don't have other documentation gaps in another. And like you said, when there's so many choices as to where the information goes, even if you do a great job of educating everyone to put it in one place, it doesn't always pull through, and it doesn't pull through on the documentation that really makes a difference in risk adjustment and in payments.
Right. We have 20,000 people who have access to NEMG's EMR, and trying to educate that many people to do anything correctly in the EMR is almost impossible.
You have job security, Bill.
Yeah, that's a good point, Bill. Absolutely. Bill, if you don't mind, are you able to talk about, you said the IT staff made it more obvious for the users. Are you able to talk about that a little bit?
Yeah, I can only talk about it specifically for Epic. But Epic has a health maintenance module where for each patient you could pull up the health maintenance status for about 20 different health issues for that patient, ranging from vaccinations to colonoscopies to hemoglobin A1C, for example, in diabetics. The most critical thing our IT people did was to make sure that any lab reports are appropriately input into the health maintenance so that we would capture the hemoglobin A1Cs, and that when we would scan something into the media section of Epic, that it would be pulled into the health maintenance module. If you don't do that, you have to go back in every patient and look in the media section of Epic to see if they had a colonoscopy, a mammogram, and no one was going to do that. So I can't speak to other EMRs, but there are, as these EMRs become more complex, it even becomes more complex to translate the information you're putting in there into the correct place so that you can pull it. So we actually have a structured data system with most of our providers, most of our payers, which automatically pulls information from Epic in data files that go to the insurers. And we had a lot of trouble getting the correct structured data input into the files that were coming out of Epic. We've taken about a year to get that under control, and now we're able to send routinely all BMIs, hemoglobin A1Cs, mammograms, diabetic eye exams, et cetera, all every month in a file that goes to our insurers. And that's really made our HEDIS measures go from what was initially a HEDIS level of 3 to a HEDIS level of 4.5. So if you put the work into it, that data is there in the EMR. You just have to know how to get it out.
Thanks so much, Bill. I think that was a good explanation for the audience, just in case, it's a practical answer that they can maybe learn from an input as well, possibly. So thank you for taking the time to do that. Donna, I want to go over to you. The survey results also showed that only 41% of respondents felt they had the ability to look at risk prospectively. Could you give us your thoughts on that?
Sure. Well, and especially if the EHR is the primary source of this information, it does a great job of showing what's kind of happening concurrently and what's happened in the past. But the payment system for many of these risk populations is prospective, meaning that the current care and the current documentation is going to predict how much revenue that organization or that provider is going to receive in the future. And so it's very important from healthcare organizations work on such thin margins that it's absolutely critical that they're able to budget, they're able to predict that revenue, and they're able to budget accordingly. And all of the services, especially in a managed population, that they want to supply, programs, care coordination, navigators, et cetera, all of that has to be taken into account in their budgeting as well. So the better they're able to understand what their current population looks like, address any gaps that they have, predict the revenue they're going to have in the future, and then create the programs that their patients could benefit from to better manage them. So it's a prospective system, and a lot of times just a current view of the state without understanding, what CMS's view, for example, of risk adjustment is, really disadvantages the organization from being able to budget and develop for programs that population needs.
I would just emphasize that if you don't know what's going on now, I don't see how you could adjust a phase risk adjustment prospectively. The most important thing is to get what's going on now and then to extrapolate from that.
Sure.
All right. Bill, to bring this topic full circle, what are some of the key best practices to ensuring behavior change across providers?
Based on all the data we've been receiving from SCIO, including risk assessment factors for each provider, missing HCCs per patient, and a global perspective of how we as a medical system compare nationally with coding HCCs, we've undertaken a major program on education. We have had 250 providers attend HCC coding boot camps, we call them. We've instituted for the largest providers number-wise and with sort of mediocre risk factors, we've engaged in one-on-one education where I go and educate the providers on the 10 or 12 most important HCC codes for them to address. We can't have them learn all 79 codes. That's what happens at the boot camp, and they come out of the boot camp not really able to assess a patient's HCC status well. So we have them concentrating on things that are very important for us to capture, such as diabetic complications, morbid obesity, vascular conditions, depression, 10 to 12 things that we've identified, but more importantly, SCIO has confirmed that these are the HCC codes that we are not doing well. At the same time, there are some codes that we're overcoding, and that was a surprise to us. Since we're not doing that well with coding, we didn't think that we would really have overcoding. But as I mentioned before, cancer codes, the patient has to have active disease or under treatment. Otherwise, they don't have an HCC code for cancer. So those are all things that we're addressing with providers on one-on-one education. And SCIO is, at the present time, auditing charts of providers that we think are the biggest outliers in doing a good job on HCC coding. We are going to use the results of that audit to, again, go visit with the provider, talk to them about their specific problems with HCC coding, see how they do for a couple of months with the education we've given them, and then re-audit their charts and then revisit them. And I would expect we would see some significant improvements in risk factor for their panel of patients.
Yeah, I have to echo that. I think that, behavior change is the hardest thing to do, and it takes time to achieve. First, you have to know your benchmark, and education can be especially effective if it's very specific and targeted to exactly where that provider has missed some diagnoses and some documentation because of lack of knowledge, just not knowing the right way to do it that would be picked up on throughout the system and adjust risks. But it takes time. It takes not only the boot camps and the one-on-one education, the specific examples to them. It takes some re-auditing to make sure that indeed that change was made. And it takes a lot of reinforcement. And reinforcement can, take a lot of flavors, anywhere from just continual education to incentives that are designed as well to have a more accurate picture. But also it takes a lot of focus, it takes time, it's hard work, and it requires first and foremost visibility to the issue. It takes visibility, comprehensive data, understanding where the problems are, targeting them, not trying to boil the ocean, we always say, but trying to be very specific with where the outliers are that you can have the most impact on, and continual, very specific education, re-auditing, and reinforcement.
I don't think you could overemphasize the importance of documentation. Our high number of patient providers are not doing the greatest job at documentation. So even though we're identifying HCC codes in the chart that could have been documented and could have been billed, we're not seeing adequate documentation for that HCC code. So even though we're going in and reviewing the charts and could recapture some of these codes, because the documentation is so poor, we can't. What some of our regional medical groups have done, and we have not taken this approach yet, for the providers, they've actually made 20% of salary dependent on how good they do on HCC coding based on audits. We're not in a punitive method yet at NEMG. I think we're going to actually bonus people who do a good job rather than penalize people who aren't doing a good job, at least until we have the full educational program out there.